So next topic is carcinoma endometrium. So carcinoma endometrium or endometrial carcinoma is only estrogen dependent cancer. So as we discussed earlier, carcinoma ovary is not estrogen dependent, and similarly carcinoma cervix is not estrogen dependent. So who are all who are all have the increased risk factors or predisposed to endometrial cancer is old age, nulliparous women. So old age and nulliparous women are those you can even see in carcinoma ovary. So mostly similar risk factors. Other than that, what are the risk factors with decreased carcinoma is that pregnancy, because there's less of estrogen. Similarly, lactation, you'll have less of estrogen. Another important factor is that obesity. Obesity is tense because of aromatization. It's a process called aromatization. That you'll have increased estrogen, so that obesity will increase the risk factors. And there's a syndrome called corpus cancer syndrome, where you have a female will have obesity, diabetes, hypertension, along with endometrial carcinoma, and it is associated with Lynch syndrome, that is HNPCC mutation. HNPCC mutation, Lynch syndrome is present. So what are the protective risk factors you see? OCP, smoking, multiparous, very similar to that of carcinoma ovary. And other than that, PCOS, these are all increased estrogen conditions like PCOS, allele late menopause. When you give hormone replacement therapy along only with estrogen will increase the risk factor. And also tamoxifen is again will increase the estrogen. So the because it's an antagonist to estrogen receptor at breast, only at breast, not at uterus. So what happens is that endometrial cancer becomes more. So again, I've told you HNPCC, which is seen in corpus cancer syndrome because of mismatch of MLH1, 2, 6 and PMS2. These are all the mutations with mismatched repair genes which can cause of cancer. So you will have colon cancer, stomach cancer, ovarian cancer and everything. Now endometrial cancer, it is mostly adenocarcinoma, and you can also have other types like papillary serous, clear cell, mixed Mullerian tumor or carcinosarcoma. So what is this endometrial cancer is that basically there's stroma and glands in the endometrium. Because the glands are more, you'll have more of adenocarcinoma. So that is that. And you have two types of endometrial cancer, type 1 and type 2. Now type 1 is estrogen dependent. So this is what is important. Type 1 is estrogen dependent, type 2 is not estrogen dependent. So this will have best prognosis. Type 1 will have best prognosis, and this is about a worst prognosis. Also, what are the risk factors for type 1 cancer is that you have a mutation, that is P10 KRAS mutation. Also obesity, all these people will have type 1 endometrial carcinoma. Type 2 is mostly P53 mutation. And who young people will be subjected to type 1 carcinoma. That is, young doesn't mean 20s 30s, 40 55 to 65 years will be subjected to type 1. Old patient postmenopausal 65 to 75 years will be subjected to type 2 carcinoma. I have told you P10 and KRAS is for type 1, P53 HER2 new mutation will be type 2. And what is the investigation of choice for type 1 is that for investigation of choice we will mostly give biopsy in case of type 1, and for type 2 you go for MRI. So that is that. And also most common histology, we talked about adenocarcinoma, so this is that. And here the name is called as endometrial just a second. The name is called a serous endometrial intraepithelial carcinoma. I'll give you this. So 55, same thing. Obesity, hypertension, endometrioid, serous is the atypical hyperplasia, same thing. And then it is mostly like the behavior is that it is spread by lymphatic, and this is aggressive. Type 2 is aggressive. We talked about this is worst prognosis, right? So this is Endometrial hyperplasia is different from endometrial cancer, because there's a difference between hyperplasia and cancer. In case of hyperplasia, the ratio between the glands and the stroma will just be increased, but you will not have atypical cells. So that okay, yeah, sorry, this thickness of endometrium due to increased proliferation of glands, not stroma, just mostly of the glands. That is why it's called as endometrial hyperplasia. Okay, now you can divide endometrial hyperplasia into two types, again with atypia and without atypia. With atypia is simple, complex. Without atypia again is simple and complex. Now without atypia, simple will be, it goes like this. There's a very fast progression into the endometrial cancer. That is within a period of 6 months to 1 year, it can easily progress. Just like that, it can progress to endometrial cancer. Now in case of simple, the glands will be more and the stroma will be less. In case of complex, both glands and stroma will be more, and then this depends upon the atypia. Now this is the progression, of which there's a percentage progression to endometrial cancer. This will 1%, 3%, 8%, 30%. It's just simple. Alright, now for endometrial cancer, endometrial hyperplasia, what do you do is that first you have to do a transvaginal ultrasound, transvaginal scan to measure the endometrial thickness. Now when do you start measuring endometrial thickness is, see, for a patient, a postmenopausal patient, if the thickness is more than 4 mm, and then you go into other further treatment. Perimenopausal, more than 10. Also, other than that, you have a hyperechoic shadow or irregular outlines. Vascularity is more, vascular resistance is less. If the vascular resistance is less, you will have increased chances of bleeding. Increased chances of bleeding will be there, and then you have intrauterine fluid. If you see intrauterine fluid, these are all USG findings. So that is why you see this. Now again, the cutoff is it's given here. See, for transvaginal cutoff, for postmenopausal women, if it's more than 4 mm, you start suspecting endometrial hyperplasia. For perimenopausal women, if it's more than 10 mm, you start suspecting this. Now once you do this, you can also do other factors like pipette, where you can aspirate and curate sampling can be done. These are all investigations for endometrial thickness, but the gold standard is, for staging, it is surgery, which is always like laparotomy, and for diagnosis is fractional curettage. Another thing is, never do hysterectomy in endometrial cancer because it can spill into the peritoneum. So that that point can be cancelled out. Alright, so I don't think so all these are required. Okay, now management. So management for without atypia, which is considered to be less dangerous, you have to give progesterone. So it's an estrogen dependent tumor. You have to give progesterone, hydroxyprogesterone acetate, for 21 days and for 3 months, and for that is the first choice. And second choice, you can give Marina, which is the second levonorgestrel. You have no systemic side effects, and you can also repeat booster after 3 months, and it can cure within 6 to 12 months. If you have persistent symptoms, you can do hysterectomy. Now if you have with atypia, the first choice itself will be hysterectomy. In case of perimenopausal women, that is who do not want pregnancy, you can also do hysterectomy. In postmenopausal, everyone you'll do. If you need fertility, if they want pregnancy to happen, in case of that, you just give high dose progesterone. But always there's a risk of endometrial cancer, even if you give high dose of progesterone. But you have to do regular TBS and endometrial biopsy. So that is that.